So it might be difficult for you to understand some of the issues which we'll be discussing. So I'll try and give a bit of background information regarding HIV, so that when you then do some of the program lectures, you'll be able to understand some of the issues. You'll be able to understand some of the issues which will be discussed. So it will be more of really basic issues regarding HIV and AIDS, but yeah. So the first, I think it's just a definition. I hope all of you are aware of what is the meaning of HIV and AIDS, where HIV stands for human immunodeficient virus, and AIDS and HIV stands for human immunodeficient virus, the virus which causes AIDS. Then for AIDS, it stands for acquired immunodeficient syndrome, and this refers to the most advanced stage of HIV infection. So the A it just stands for acquired. This tries to differentiate. There are several ways in which diseases, in which there are several ways in which people get disease. Some of the disease, they are infectious disease, what we are discussing. Some disease, they are genetic or inherited, but for HIV, it's acquired. The way they acquired, I think, is more or less the same as communicable disease. Then I stands for immuno, which refers to the immune system. Then D, deficiency. Deficiency just means now the body won't be able to protect itself against the illness. Then syndrome, it's a group of symptoms now that's okay as a result of HIV infection. So that's the meaning of the word AIDS. I think there's also been a challenge in terms of people not understanding the difference between HIV and AIDS. HIV is the virus which causes AIDS. So if you get HIV, usually we say you've got HIV infection. So this HIV infection can then progresses to AIDS, which is now a group of serious illnesses and opportunistic infection. So the virus, it damages the immune system. So it damages the immune system. When the immune system is weak, it then becomes prone to getting opportunistic infection. We call them opportunistic infections. Why? Because they are taking opportunity of a weak system which has been damaged by the virus. So for most people who acquire HIV infection, they don't really progress to AIDS, but some of them, they can take time to really progress to HIV. I think some can even take time, even up to 15 years, for them to develop AIDS. But usually, there are several factors which influence how people progress either from HIV infection to AIDS. In terms of the epidemiology of HIV, in terms of the statistics, just describing the number which is affected, globally, regionally, and even locally. I will not give you the latest statistics in this presentation, but I encourage you to go to the UNAIDS website where you can look for the latest statistics. So I think you can look for the global report for I think the global report for 2019 or 2020, I think it should be available, where you can get the latest statistics in terms of the number of people who are affected with HIV globally, the number of people on Earth, the number of new infections, yeah. So I think you can check all those things on that website. In terms of our local statistics, we will have someone from the Ministry of Health, AIDS and TB unit, who will give us our local statistics in terms of the number of people who are infected with HIV. So I think you'll get those statistics from the Ministry of Health, guys from AIDS and TB units, maybe next week. So I'll not really go discuss much in terms of those statistics. Then in terms of HIV transmission, there are three main ways in which HIV is transmitted. We have sexual intercourse, mother to child, and others. So for sexual, people usually tend to think sexual is the heterosexual, which is the sex between men and women. But I think there are also more other, types of sex. We have got heterosexual, we have homosexual, we also have oral sex among the types of sex. So these the someone has a question. Helen, can you mute yourself? Helen, yeah, no, thank you. So these are like the heterosexual, the homosexual, but I think the most type of sex which we have within our setting is the heterosexual between men and women, and as part of that, the element of oral sex also really is very common. But people really don't discuss about these issues. The risk of getting HIV is there, between all these forms of sex, but the higher risk, if you're comparing the three, is mainly through the homosexual. But remember, for homosexual and heterosexual, we have got, we have got the receiver and the incentive. So the risk of getting HIV infection for heterosexual or homosexual, there's difference between the incentive and the receiver. So maybe I might need to ask you in terms of the risk for homosexual, for heterosexual. So the receiver is like the woman, and then the man is the incentive. Can someone comment who has the higher risk of getting HIV infection if you are comparing those two, men or women? Someone to comment on that, who has high risk of getting HIV infection during a sexual act, assuming vice versa, either the man is positive or the woman is positive, and why, if there's a difference, uh, why do we have that difference? Anyone to comment with an answer? No one. Try more. Yes, you can go ahead. I see you've unmuted yourself.
I think the woman is a high risk because of the increased surface area during intercourse.
Of what?
And there is an increased surface area during intercourse, so the women is more likely to get HIV infection than the men.
Yes, so I think you can read through. I think that's correct to say women have a higher risk of getting HIV, assuming either men or the woman is HIV positive. The risk is high in women. There are several reasons. There are biological factors. I think one of the reasons which you mentioned, which is the issue of surface area, and then the issue of moisture and all those things, they really increase the risk of HIV infection. But you also have economic issues, you also have cultural issues, our society in terms of how we treat men, it then really puts women at high risk of getting HIV infection. This then becomes important now in terms of programming. I think we have had a lot of issues, HIV programs really targeting women. Today, I think these days we've got the DREAMS program, which really try to focus to try to empower women because of that discrepancy between men and women in terms of the risk of getting HIV infection. Then for homosexual, we have the incentive and the receptive. Who has a higher risk of getting HIV, the receptive or the incentive? Anyone to answer? yeah, maybe you can look into that and to try to see. But I think these days, as a country, we used to be really shy, not open enough to discuss about some of these issues to do with homosexual men. Yes, I saw Onai, you admit yourself. You want to say something? Onai Maparara, do you want to say something, or it was a mistake to I am? No, that's perfect. So these days, there's a lot of now, starting programs to be implemented regarding homosexual because of their risk of getting HIV infection. Talents.
Yes, talk.
Yes. You want to respond to the questions? So in terms of, so I think we are going to have a lecture from the Minister of Health where we'll be discussing about key populations, where we'll discuss the national key population program, where some of these issues will be discussed openly so that you understand. Then mother to child, I have a few slides which I'll discuss how HIV can be transmitted from mother to child. Then there are others, usually this is blood exposure, either through, through pricking, through some of the other things. So you can also have that. But most of the HIV infection really occurs through number one, which is the sexual intercourse. Then we've got the mother to child and others, they contribute a very small proportion. Then this diagram just summarizes in terms of the HIV infection in Zimbabwe. It is in terms of really trying to try to summarize the sources of in terms of the contribution of HIV infection within Zimbabwe. If you see from the top, most of the infection, 80% of the infection, they occur among adults and only 20% are within children. If you look in terms of the proportion now, you have 94% of the infections occurring in heterosexual. Remember, we discussed that we have got heterosexual, we have got homosexual. So the MSM, which is the homosexual, they also have a contribution, which is around 4%. Then intravenous drug use between 0.1 to 1%. Then you've got the vertical transmission, which is mother to child. So issues to do with blood, but this is very rare because our systems we screen before people are given blood. Then we've got our vertical transmission. But if you look for the heterosexual transmission, you realize that in terms of most of the in terms of the contribution, we also have the sex work. The sex workers, now we've got the sex and their clients contributing around 13%. And then we've got issues to do with concurrent partnerships also contributing. But one of the surprising thing from this survey, it was the transmission within stable relationships. I hope you know when people are now in a stable relationships, one of them which is marriage, in terms of trusting each other and in terms of really to use condoms, the risk is very low. So because of that, actually, most of the HIV transmissions, they are seen to happen within stable relationships. So we also have other features, other structural features like socio-economic, cultural, economic, gender issues, which really play a role in terms of increasing the risk of HIV transmission. Then Pascal, can you mute yourself? Thank you. Then in terms of risk of HIV transmission, These are some of the things which increase the risk of HIV transmission during a sexual act. The frequency and duration, the number of sexual partners, whether you're using protection or not, the stage of HIV infection. This relates, the advanced the HIV is, the higher your viral load. So the higher the viral load, the higher the risk of HIV transmission. Then the nature of sex, I think we have heard, there are some of these things which people do to try to enhance sex. I think there's a belief that tight sex is the best. So because of that, you then increase the risk of having bruises or injuries, which then increases the risk of getting HIV infection. Then sexually transmitted infections, they also increase the risk, especially those which are ulcerative. Circumcision reduces the risk. Then if you're on ART, it means your viral load will be reduced, so the risk of transmission becomes lower. Then the age, it has to really do with maturity when you're negotiating for sex. Then in terms of mother to child, if you don't do anything, the risk of really acquiring HIV infection from a mother to child is not 100%. Not all mothers who are HIV positive transmit the virus to their children. Only around 15 to 40% transmit the virus to their children. And in those cases, 25% they're okay in pregnancy, then delivery around 60%, then breastfeeding around 15%. Then we have got also factors which increase this risk of the virus passing from the mother to child. If the mother has advanced disease, high viral load, remember I mentioned that the higher the viral load, the higher the risk of HIV transmission. We also have prolonged premature of membrane chorioamnitis, also increasing the risk of getting infection. But these days, on Monday, we'll have a lecture with from the AIDS and TB unit where we'll be discussing about the EMTCT, which is elimination of mother-to-child transmission of where these days actually we are trying to eliminate this because of the use of antiretroviral therapy. But yeah, in some cases, where people can deliver through cesarean section or avoiding breastfeeding. But for us, really our main approach in terms of reducing mother-to-child transmission is not through the last two, where we talk of cesarean section and avoid breastfeeding, but is mainly through the provision of antiretroviral therapy. I hope you remember, some of you, we used to have the option B+, where we are giving all mothers who are HIV positive, starting them on ART. So I think that's the priority as opposed to really some of these other issues which are mentioned. But if you go to some of the countries, developed countries, they really, some of those issues, they are discussed. Then you can also have other things which might cause transmission of HIV. I think these ones, they happen, they can happen. But I think these days, because of awareness and people are being taught, it's very rare to have people getting HIV infection through some of these things, like an unsterilized use of objects, traditional healers, drug abuse. I think we discussed this, but most of the top three, the artificial insemination, whatever, grafting and blood products, a lot of screening happens before people are given treatment, which then reduces the risk. But we also have occupational risks, where healthcare workers, remember, they will be dealing with patients. Some of the patients might be HIV positive. So, during some of the procedures, like collecting blood, surgery, there's also really some risk of HIV passing from the patients to the healthcare workers. But in case we always have protocols within our system. I think you've heard of what we call the post-exposure prophylaxis. These are drugs which are taken in case someone someone is involved in such an accident. Then there is no, some of these things, I think people used to really think HIV can be transmitted in some of these things. But actually there is no supporting evidence that HIV can be acquired through some of the mentioned issues. But in some of the body fluids, there is low viral titer. The concentration is low, but which then actually, yes, the risk of HIV transmission might be there, but it will be very low if you are exposed to some of those body fluids. Then I think for you to really understand the HIV issues, we need to really discuss a bit of immunology. I'll just give you one slide where I summarize some of the immunological issues which are key for you to understand HIV. So as I mentioned from the start, we say the HIV virus, it affects the immune system, thereby causing an immunodeficiency, which is a weakness of the immune system. But for you to really understand that, you need to appreciate a bit basics of the immune system. So here, I think you might add this, maybe when you get your notes, because usually we have got your blood cells, out of those blood cells, we have 3 types of blood cells. We have got red blood cells, which are responsible for oxygen, and they contain hemoglobin. Then we have got platelets. Platelets are responsible for clotting. Let's say, you have been cut and you're bleeding. To stop that bleeding, you need, the platelets are the ones which are responsible to stop the bleeding. Then we have got white blood cells, which are responsible for the immune system in terms of protecting us against infections. We have several types of white blood cells. So I think in this graph, we just saw an example of some of those cells. We've got neutrophils, we've got lymphocytes, we've got monocytes, we've got macrophages, and they have different roles and different functions within the body. But we have special cells which we call lymphocytes, and these lymphocytes, we have got 2 types of the lymphocytes. We have B cells or B lymphocytes and T lymphocytes. So the B cells, they produce antibodies. Antibodies, I know when people are talking about the immune system, you talk much about antibodies. Antibodies, they are not like really cells, but they are molecules which are produced by cells of the immune system. And they've got a lot of other functions, either they neutralize, toxic things. They also have other functions actually to try to stop, the bugs from invading us. Then we have got your T lymphocytes, which are classified into 2. We have got CD4 cells and CD8. So the CD8 cells, remember, we have got 2 types of, in terms of infections. We can have what we call intracellular or extracellular infections. So for intracellular infections, we have the CD4 cell, the CD8 cells, which actually really are responsible for destroying infections which are inside, which are intracellular. And we call them cytotoxic cells, which means they really kill cells with infections. Then usually for extracellular, we have your neutrophils, your monocytes, and your macrophages actually assisting in controlling those infections. I hope you have heard of this word of engulfing. It's like eating, some of this extracellular infection. I think we used to learn this word in maybe in high school. Even if when you did your biology, I think, or your physiology, you might have heard that concept. Then on the T cells, you have your CD4 cells. Your CD4 cells, they don't really attack. Your infections directly, but they have several roles. They have what we call, they've got several roles in terms of this slide. Just really try to summarize in terms of what the CD4 cell does. which actually it kind of really coordinates or stimulates other cells of the immune system to perform whatever function they are supposed to perform. So, for example, for the B cells, it makes sure they mature into plasma cells, which then produce antibodies. To the CD8, it produces stimulus, which makes sure they do what they're supposed to do. So this CD4 cell is like a central cell, which has like a coordinating role in coordinating other cells of the immune system in terms of how they are supposed to operate or how they are supposed to function. And this is the cell which is destroyed by HIV. So this is the cell which is targeted by HIV, and this is the cell which is destroyed by HIV. And that's why we see, the impact of HIV is significant. Why? Because you are targeting, this cell which is key in coordinating the immune system. So you're like killing. Let's take for example, it's an army. You're like attacking the commander of the commander in chief of whatever for the army, which means the army will no longer be really effective in terms of fighting and responding. So that's why you see the immunosuppressive effect of HIV. They are so huge because you'll be targeting a central cell. Then this graph, I'll not go in detail about this graph, but this graph just really shows in terms of the natural history of HIV infection. If someone gets HIV infection, what are the stages, which they pass through? So if you see, there are two graphs, and the red graph, it shows the viral load in terms of the amount of viral copies, and as one progresses. Then the blue graph is showing the immune system. So if you see these two, they're going opposite. So before infection, you will not have the virus, but after infection, the virus will start multiplying, and as the virus multiplies, it then starts destroying and it cells of your immune system. At some points, usually at some points, why does the virus go up? It's because in most cases, you won't be having an immune system against the virus. But as you start to develop, as you start to mount an immune system against the virus will then drop, and your immune system will recover a bit, but you will not really recover, going back to the maximum. Then you have a balance between your immune system and the virus over some time, where we call this period clinical latence. Then from there, after some time, the immune system will be overpowered by the virus. So the virus will multiply, significantly, having opportunistic infections, then death, and the immune system will be gradually going down. So this is just, I'll not really go in detail with this graph, but just understand the progression of HIV in terms of when you get HIV infection too. But this is no longer like the typical path now these days because of antiretroviral therapy. So because of antiretroviral therapy, I think the course of HIV now is changed. So you don't have now, it's like if you've got HIV infection, if you get treatment, instead of this viral, the rate going up, now it's almost like really going down, and your immune system, remaining up without really the two crossing because of antiretroviral therapy. So I think this just shows another graph which just really shows in terms of your CD4 count, which is destroyed by HIV with time. As your CD4 count decreases, you now have opportunistic infections develop. So, some of these opportunistic infections, they develop depending on the level of your CD4 count. So the early things to develop are your skin diseases, but later, you can have some of these other severe conditions, developing later. So, this same graph, actually, in terms of this progression, there is what we call the WHO staging now. the criteria which is used to stage in terms of the progression of HIV disease. So I think you can see the early stages will be like in stage 1, then as you progress stage 2, as you progress stage 3, as you progress, that will be the last stage, which is stage 4. So these days, no longer really talk much about who staging, but I think it is critical to understand there's a way of assessing the progression of HIV. I see some of you are unmuting themselves. If you want to say something or you want to ask, feel free to raise your hand. Then I will try and stop so that if you need clarification, I can try and address those whatever issue you might have. Then in terms of HIV testing, we have 2 types of HIV testing. And we have what we call direct test, where we test for the virus itself. In this case, we can do the viral culture or we can test for the genes. But usually we don't do viral culture. We test for the genes. And the most test which we do is a DNA PCR, where we are looking for the gene of the virus. Then the common test which we do, these are antibody tests. The antibody test, we are not testing for the HIV itself, but we are testing for the presence of antibodies which are produced in response to the HIV infection. Then in terms of some of these issues, you might have heard them. I think you've done this when you are doing your epidemiology, where we discuss, in terms of diagnostic tests, in terms of their performance, issues to do with specificity, issues to do with sensitivity, and the testing procedure, where the first test usually is a screening test. If someone is negative, then that's fine. But if they are positive, you need to do a confirmatory test. And the way these tests are sequenced in terms of which one start, which one whatever, it has to really do with specificity and sensitivity. I hope you understand these words. Can someone define specificity? Any of those 2? What is specificity? What is sensitivity? What is specificity of a test? What is sensitivity of a test? Did you do these things? Did you do this class rep? Did you have a session where you discuss sensitivity and specificity? Please, you admit. Yes.
Yes, we did.
So why are you struggling to define this? No, I know it's confusing, and it takes time to really master it. So you need to kind of really understand it, because there's specificity, there's sensitivity, there's predictive value, positive, and negative. So you need to understand. The other one is about test. The other one is about what? About disease. So just understand those 2. Yeah, understand those things and try to go back to your notes and read those concepts. Then there's the issue of the window period, which is the time before seroconversion, before formation of antibodies. Usually we use the 3 months period, which is the 12 weeks. And that's why you always say if you test negative, you come back at 12 weeks. Why? Because by 12 weeks, most people who have acquired HIV will then, and by that time, they'll have developed antibodies, which is 100%. But by 6 weeks, 80% actually will have developed antibodies. And we have other cases which actually takes time for them to develop antibodies. And it can even go up to 6 months without developing antibodies. Then this is very important. I'll not go in detail in terms of how we diagnose HIV in infants. In terms of infants, in infants, remember, maybe the first sentence that is very critical for you to understand to say antibodies usually, and any antibodies, they cross from the mother to go to the child, so that the child is protected from whatever infections. If the mother is HIV positive, it means the antibodies for the mother will also cross into the baby. So in terms of our testing now, remember, if you remember the first slide, the slide where I was discussing about mother to child, not all mothers who are HIV positive and who have the virus passed to their child. So because of that, but the antibodies, they always cross from the mother to the G, and they always cross from the mother to the child. So which means if you use an antibody test, there's a high chance of having a false positive G results. So that's why I think you realize that in children, usually we don't recommend doing antibody test, but we recommend doing a PCR test. And usually we need to do this at least 6 weeks after cessation of exposure. Remember, the child can be exposed to the virus either during pregnancy or during breastfeeding. So I think this is a very important concept which you need to understand in terms of testing in infants and testing because of this issue of antibodies. Then I'll briefly discuss the structure of the HIV virus, because you need to understand this to also to appreciate. I think one of the issues which we need to pick from this lesson, some of the things you just need to appreciate, and you don't really stress yourself trying to master some of them, but at least have some idea in terms of in terms of the flow, in terms of the issues, but don't really stress yourself. Try to master some of these basic. I'll be happy if you can just appreciate in terms of this. So in terms of the HIV structure, I'll just discuss 3 main components of the structure, which are key in terms of whatever I want to discuss in the next few slides. It has a membrane outside, which we call a lipoprotein membrane. Then in that lipoprotein membrane, we have what we call glycoproteins or proteins within the membrane. We have got 2 proteins, actually, they are part of the membrane. They are inserted within the membrane. There's the GP120 and the GP141. We have got the matrix, which is more or less like the cytoplasm of the HIV virus. Then we have got the proteic nucleic acid components, and it is like the nucleus, where you have got, in terms of classification of viruses, we have got RNA viruses and DNA viruses. So for the HIV virus, it's an RNA virus, and in its nuclear component, we have 2 copies of RNA. Then we've got 3 enzymes within the nucleus, which are really part of its replication. We've got the reverse transcriptase enzyme, the integrase enzyme, and the protease enzyme, which are part of the nuclear component of the virus. So this is like the structure of the virus in terms of how it appears. We have your membrane and all these things, and this is just a pictorial appearance of HIV virus. But just take note of the 3 issues I mentioned. You have got your membrane, and it has got these proteins which are inserted. These are the lipoproteins, like a noble carrier. This is the handle now. This one is the GP41, whereas this one is the GP120, the knob. Then you have got your nucleus, and in the nucleus you have your 3 membranes, your reverse transcriptase, your integrase, and your protease. So these things are important for you to appreciate. Why? Because they help you appreciate the HIV life cycle. So in terms of how does the HIV virus multiplies, or how does the HIV virus in terms of how it multiplies. So I'll quickly go over the HIV life cycle in terms of some of the steps which happens. So the HIV virus, remember, as we said, This yellow, this sort of a pink, sorry, it's not pink, it's what color? Brown thing with the yellow strand. That's our HIV virus. For it to multiply, it uses the CD4 cell. And it uses, remember, that's why I gave you that slide on the HIV, on the immune system, because I wanted you to appreciate that for the HIV virus to multiply, it uses the CD4 cells. And the first step in terms of that HIV life cycle for the HIV, it attaches to the CD4 cell. And how does it attach? It attaches to the CD4 cell through a CD4 receptor. So there's a receptor on the CD4 cell through which the HIV virus attaches. Then after it attaches, what happens? The next stage now, remember, as I mentioned, to say inside the HIV virus, it is an RNA strand, and so that RNA strand within the virus is converted into a DNA. For this whole process, remember, the whole process of life cycle is to multiply. For cells to multiply, in most cases, for cells to multiply, we use DNA. So the HIV virus contains what? Contains RNA. So it has to be changed to DNA. And so when the enzyme reverse transcriptase, it changes the HIV RNA to DNA. This is now the HIV DNA. This HIV DNA is now integrated or becomes part of the human DNA. And so when this big cell, remember, when this big CD4 cell is multiplying, it will also multiply the components on it. It will also multiply the elements of the HIV virus. And so during that process now of multiplying, and when this big CD4 cell is multiplying, it also produces the viral components of the virus. The membrane, and the DNA, and these DNA materials, they then assemble to form, they then combine, assemble to form new viruses, which are then releasing through budding. So it's not, please don't memorize this if you're not like really medical, but just understand to say, for the virus to multiply, that's what happens in terms of the process from attachment. It changes to DNA by an enzyme called reverse transcriptase. Then it is integrated into the host cell by the integrase enzyme. And then when the big CD4 cell is now multiplying, it's also multiplying the viral components. But these viral components, most of them, they'll be like polyproteins or very big. The other enzyme, which is protease, will then chop those bigger components, into smaller proteins, which then assemble and form new virus, which are released during budding. Why is it important now for you to understand this life cycle? It is important for you to understand it because in terms of our HIV treatment, and our HIV treatment, the drugs which we use, we don't have drugs, we don't have cure for HIV, but what we do, the drugs which we have, they act on the HIV life cycle to try to stop the multiplication of the virus. So these drugs which we have, usually they act on the enzymes which I have mentioned now, so that they stop this whole process of multiplication, thereby reducing the viral load. So we have got drugs which targets the first point, which is the attachment or the entry, where we have got fusion or entry inhibitors. Then we have our CD4 receptor and another co-receptor, which assists the virus to enter into the CD4 cell. So we have other drugs which we call co-receptor antagonist. Then remember, as I mentioned, we have the RNA is converted into DNA. We have got drugs which stop that process. those are called reverse transcriptase inhibitors, and they are inhibiting that process. That's the way reverse transcriptase inhibitors. Then we have drugs that act at integration, and these are called, it's not integration, it's integrase inhibitor. Remember, I said these drugs, they act on enzymes, where they target what? They target enzymes. Then we have protease inhibitors, which targets the protease enzyme. So I think that's the whole purpose why I was explaining to you the HIV life cycle. At least you understand where some of the drugs which are used for HIV treatment work. But I think as part of HIV programming, there'll be a lot of talk of drugs, people saying reverse transcriptase inhibitors, protease inhibitors, and whatever, integrase inhibitors. So it will be critical to then understand some of those issues. Because if you don't understand some of those issues, then yeah, you know, as a program manager or someone who's involved in implementation, it will be key for you really to pick some of those things, because either you're from the lab, you're from the data, you're from whatever actual implementation. So it's really for you to appreciate where these drugs will be acting. So now you have an appreciation of how the HIV drugs work. Then I think I'll give another, the next slides, I'll try to give now in terms of the actual, how HIV is managed, you know, what are the issues which you need to consider. So before we start people on treatment, usually we have got goals and we have got aims or goals. Why do we really put people on treatment? So we have got at least 5 goals in terms of why we start people on HIV treatment. We have got clinical goals, we have got virologic goals, we have got immunologic goals, we have therapeutic goals, and epidemiologic goals. In terms of clinical goals, it's all about really improving the quality of life and reducing HIV morbidity and mortality. In terms of virologic goals, it's all about making sure you know, there's durable and maximum viral suppression and prevent and delay HIV resistance. Then immunologic goals is to restore the immune system. Remember, as we said, the HIV virus attacks the immune system. So as part of our immunologic goals, it's also critical to make sure we restore the immune system. We also have therapeutic goals in terms of how we give, you know, we give drugs, the sequencing of drugs, the regimens which we give, in terms of how we, you know, to try to maximize adherence and prevent side effects. We also have epidemiologic goals now. Remember, these days, if to those who are in HIV, we talk of treat all, and one of the reasons why we are now starting people on treatment is mainly for epidemiological goals, where we want to reduce HIV transmission. So one of the reasons why, I think you've heard the concept of treatment as prevention. And how does this treatment as prevention work? It works by, you know, if you put people who are HIV positive on treatment, it means you are going to reduce their viral load. If the viral load is reduced, then the risk of transmitting then becomes low. So yeah, so when people are starting on treatment, these are some of the goals, you know, which why we start people who are HIV positive on treatment. Then before we start our patients on ART, we don't just start people on treatment. There are several things which we do. We assess their history. We do a physical examination to see if they don't have any other condition. We do some lab tests. And why do you do this initial assessment? We want to see, you know, the stage of the patient. We also want to check if the patient doesn't have, you know, baseline organ damage, because some of the drugs which we give, they have got side effects of damaging some organs. So I want to see if their organs are okay. We want to rule out any opportunistic infection. Why? Because we've got what we call IRIS, which is immune reconstitution inflammatory syndrome. I'll not discuss this in detail, but it's something which you need to understand to say, if we start people on treatment without treating their underlying opportunistic infection, they can actually become sick. So it is important to make sure we screen our patients for underlying opportunistic infection so that they don't develop. Then based on the initial assessment, we can decide whether to start at or to defer, depending on whether the client is ready or is not ready. Then in terms of the guidelines on when to start treatment, this is an old slide, but I think now in terms of when to start treatment, we are now using what we have adopted the 2015 guidelines as a country, where we are now treating everyone, which is treat all, where we are treating everyone irrespective of their CD4 or clinical stage. But before, in 2013, remember I discussed the issue of WHO stage and then about CD4 count. We used to treat if the CD4 was less than or equal to 500, or if you're in WHO stage 3 or stage 4. But now we no longer really using this, and we are no longer really using this criteria. We are now treating everyone who is HIV positive, irrespective of their CD4 count or WHO stage. Why are we? Can someone maybe give a comment? Why are we now treating patients regardless of CD4 or clinical stage? What was the reason why we stopped using CD4 or clinical stage to start patients on treatment? Anyone to comment? You can raise your hand. Yes, you can unmute yourself, then give your response, Dr. Juvuru.
Okay, I think one of the reasons is about the organ damage. If we wait for CD4 count to go down, some of the organ damage would not be reversed.
Yes.
And then I think the other reason might be due to the availability of resources.
Yes, so I think that's correct to say, remember, if someone is HIV infection, I showed you that graph where we are, where we're showing the progression of HIV, the latent period where there's a balance between your immune system. Yes, it might appear as if nothing is happening, but behind the scenes, you have chronic inflammation within the body. Because of this chronic inflammation, you can end up having organ damage. So because of that, that's why these days we are recommending people to be treated as a way of preventing this organ damage which happens because of chronic inflammation, within your organs. So because of that, and also issues to do with treatment as prevention, and it's what we've discussed. That's why really we are now recommending treat all. So one thing I forgot, maybe I need to go back to this slide for you to understand. So if you get from these slides, one thing I forget to think are the abbreviations. So if you check, like here, these are reverse transcriptase inhibitors. So there are two types of these drugs, and don't really get worried about how they are classified, but understand there are two types of these. Kunema non-nucleoside, nucleoside reverse transcriptase inhibitors. So can I abbreviation now? It becomes NRTI, which means nucleoside reverse transcriptase inhibitors. Kanakuti non-nucleoside reverse transcriptase inhibitor, which is NRTI. These are drugs which act here. If when you're looking at this position, these are integrase inhibitors or II. If you're looking at here, these are protease inhibitors or PIs. So these words, PIs, II, NRTI, or whatever, they really refer to the site where these drugs will be acting. Then here we've got your core receptor antagonist, your fusion inhibitors or entry inhibitors. So you might see words like FI or EI or CRA, and they just refer to core receptor antagonist. So why did I have to go back to that slide? It was because of this. But in terms of what are the recommended now treatment regimens when you are treating people with HIV, these are the recommended treatment regimens. These are the possible combinations, and there are several of them. But in our setting, we can have 2 NRTIs. When we are treating HIV, we treat HIV triple therapy. We don't treat HIV using one drug. We treat HIV with triple therapy. And for that triple therapy, these are the possible combinations where you can have 2 NRTIs plus an NRTI, or you can have 2 NRTIs plus a PI, or you can have 2 NRTIs plus an integrase inhibitor. So these days, as a country, I think we have heard that we have moved from, maybe it's on the next slide. I will not really go in detail to try to give you examples of these drugs to say which are the NRTIs, which are the PIs, but I think it's not, yeah. If you're interested, yeah, you can always read through to get examples of these drugs. But I think for the purpose of this lecture, just understand some of this language. And in terms of really making a choice of drug which we give for our first line, there are several things which we consider before we decide which drug to give our patients. And some of the things which govern that are the effectiveness. We need to make sure we give people drugs which are effective. Adherence issues, side effects profile. We need a safer drugs. We look into potential drug interactions. If they are getting other drugs which might interact, and reduce the levels of the drugs. Issues of availability and cost, I think, of resources. Issues of resistance, issues of pregnancy, other coexisting conditions or metabolic conditions, because there's a lot of interaction, between some of these issues. So as we give people drugs, it is very critical to also really have this in mind so that we don't end up, we correct some of these issues. But during this whole process, we always involve the patient, because the patient is the one who is going to take the drugs. So the patient has to be considered, and they also need to understand, to be involved in this whole process, not really to impose some of the drug regimens on the patients. Currently in Zimbabwe, these are like our first line therapy in adults and adolescents. So these drugs, this one, for example, TDF is just tenofovir, 3TC is lamivudine, EFV is efavirenz. So this is a 2 NRTI and plus an NNRTI, for what I was explaining we had before. So then we have got also another option, which is TDF plus 3TC plus DTG, dolutegravir. And dolutegravir, this one is an integrase inhibitor. So this is an option of a 2 NRTI plus an integrase inhibitor. But of late, I understand there's been a shift where we are now moving all patients from efavirenz to DTG. Efavirenz, I think there's been also a change. So the 400, it shows the milligrams in this regimen. So we used to have an efavirenz 600, but we moved to efavirenz 400 because of the side effects. But now we're also moving away from efavirenz to DTG. So also these are the options For efavirenz, you can use nevirapine. For tenofovir, you can use AZT. Yeah. So I think these are a bit complex, but just understand, some of these issues in terms of the drugs. Just appreciate, as I said. Then some of you might need to understand we're supposed to have this talk, but I thought it might not be really necessary now to really discuss this whole issue of resistance. One of the reasons why we moved and why we are moving away from efavirenz 400 to DTG is because of this concept of primary drug resistance. Within our country, we have got systems. We have got systems which we use, to try to monitor drug resistance. So I think we have got the early warning indicator system, which is used to really monitor, the prevalence of drug resistance. We have two types of drug and resistance, where we have got primary resistance, which means you actually have resistance to a drug without taking the drug. Well, you can have resistance to what? Where you can have, then the other one is secondary resistance, where we have resistance and after taking the drug. But this one, what I'm showing here is the primary resistance. So these two drugs, the efavirenz and the nevirapine, from some survey which was done by World Health Organization around 2010, Zimbabwe, in terms of the baseline or the primary resistance, it was more than 10%, and 10% for this efavirenz and nevirapine. That's why here I was saying that was the move now, where we are moving from efavirenz to DTG. Why? Because our baseline resistance, primary resistance from that survey was more than 10%. And that was the WHO recommendation to say, because of the baseline is more than 10%, we might need to move to DTG and get a better drug because of those reasons. But initially, there were issues there in terms of this change to starting this new drug to the dolutegravir, because there were reports from Botswana, where there were data which was pointing towards development of birth defects among women of childbearing age. But I think now, with the recent data which has been published, this has been ruled out, and the drug DTG, and it is now being rolled out and is now being given to patients. These days, I no longer work much in HIV program. Anyone in programs, maybe what is the progress now in terms of patients being changed to DTG? Anyone with recent information how we have progressed? You can raise your hand and unmute yourself and give a response if you are aware of the progress. Anyone working in HIV programs? No one. Yes. Ilka, you can unmute yourself and give a response.
I'm not exactly working in programs, but last year we were promoting the use of DTG. We were saying that everybody now has to switch on. It's something that every district is now supposed to be doing, but there is a criteria for switching to DTG. It's just that I don't have the current information just now, but there is a way that they've been switching on to DTG.
Okay. No, thank you for that contribution. Maybe let's keep that question. I need to ask people from ministry when they come for the lesson, which we'll have sometime next week. Then I think there's this just try to show the comparison now in terms of combat, because remember we are moving from efavirenz to DTG. So in terms of comparing, these two in terms of in terms of potency, in terms of toxicity, in terms of genetic barrier, it just refers to the number of mutations which are required before someone develops resistance, and the availability of generic, low pill burden, use in pregnancy, use in children, use in TB, whatever. But if you compare these two, you realize actually DTG is more favorable as opposed to efavirenz. That's why there has been this move from efavirenz to this. I hope to those who are in HIV, you remember for someone to develop resistance to efavirenz, you only need one mutation, which is the genetic barrier. But for efavirenz, for DTG, you need a lot of mutations actually for you to finally have what have resistance. So you can also ask this, when this thing was published, I think it was around 2017, there were ongoing studies and there were no information on some of the issues. But now I think I gave you the issue of Botswana, where I was explaining the issue of birth defects in children. I think those issues have been resolved and the drug is now being used. But of late there have been actual issues in terms of use of DTG. In terms of side effects, anyone aware of what are some of the dangers, some of the side effects which are now starting to resurface because of DTG? I hope you also remember for efavirenz, well, it was before, remember, we were coming from nevirapine and going to nevirapine, so it was a wonder drug during those days. But as things changes, it was no longer a wonder drug. It has a lot of other side effects. People have nightmares. The male patients developing breast. I think you've seen male patients with breast, the gynecomastia, so many things. And because of that, it was phased out. So now we are also excited about DTG, but now we are having issues now which are starting to coming out. I see Yoka, your hand is up again. You can unmute yourself and Yoka, you can unmute yourself and maybe tell us some of the issues which are now coming from DTG.
Can you hear me now?
Yes.
Okay. They were talking about the exposure, especially in positive women, where they were saying there might be increased risk of neural tube defects. And also there's some side effects of insomnia, fatigue, headache, a rise in serum creatinine levels, and weight gain.
Yes, and so one of the topical issues now about DTG is the issue of weight gain. The weight gain is actually a topical, one of the side effects which is being mentioned. So I'll give you the slides, the guidelines where you can read this. Then I'll briefly discuss on the concept of how we monitor our patients. Now, I think we've discussed if our patients have started treatment. Then the next stage is monitoring those patients. The monitoring often involves monitoring the treatment response and also checking for potential side effects. Usually, we used to have a very good schedule, long back, in terms of how to see our patients, where we make sure we see them every 2 weeks, then every month for 3 months. Then from there, we scale up. But now with Treat All, I think things have changed now. I think, we are no longer really as strict and really follow up the way we used to do long back in terms of following our patients. I think now, maybe you give someone treatment, you see them after a month. Then, after a month, maybe you can give them 3 months. You already put them in a card or something. But I think things are just, changing because of the flexibility, whatever is happening. But remember, in case our patients have issues, they should be allowed to visit to visit the clinic if they have got any issues. Then these are like the side effects of drugs. And this is, I didn't put the side effects of integrase inhibitors, but I think you can put the side effects of integrase inhibitors. But our side effects, they are class specific. They depend on the class the drug is. And so if a patient is on a regimen, remember, that's why I also give that background information to say we've got our NRTIs, our NNRTIs, our PIs. Because the side effects, they depend. We have what we call class-specific side effects. We also have drug-specific specific side effects. For our NRTIs, these are most of the common side effects, and for which are used to be the kidney damage, loss of bone density, anemia. These are class. They are more of like drug-specific. But this drug, I hope you remember the era of staphylococcus, where people used to have, change in body shape, and all those, changes and deformities and the numbness. So the lipodystrophy and the numbness. That's why we removed those drugs. Then for our NRTIs, our nevirapine and the efavirenz, and they have these, the rash and the hepatitis. These are, severe in the central nervous system disturbances for efavirenz. That's why we actually stopped. Also, we are going to DTG because of those. Then our protease inhibitors, we don't use them for first line, but we use them for second line. They also have these side effects. I think this was the regimen which we were using before the regimen which we were using before the switch to DTG. But I thought it also might be nice to understand what are the side effects of each of the drug in that regimen. Our TDF, the renal damage, loss of bone density. That's why you need to frequently have patients have their renal failure measured. Then your 3TC, your lamivudine has minimal side effects. Your efavirenz, as I mentioned, the gynecomastia, the development of breast in male. This was very common. Your hepatitis, that's liver, and your liver having and your rash. These were very common. Then your central nervous system disturbances, they were also very common with the efavirenz. So you can put DTG here when you get the slides, so that since it's now the new drug which we are giving our patients. But one thing which is important to understand as public health practitioners, we have a surveillance system. We have a surveillance system which is used to monitor side effects and of underage of TB drugs and ARV drugs. So we have got a surveillance system which is managed by what do you call it? The MRCs, it's not medical, I don't know, the MCAS, I think, which were the one which deals with the drugs. They develop a system, and there are forms actually. Anyone aware of this system? Anyone who is privy in this system? Because I hope you understand as part of your MPH studies and the projects, you can also, I've seen people writing their surveillance system, actually looking into this system and evaluating this system, the HIV and TB surveillance. So it's something which you need to read about and understand, because it's a possible field topic for your surveillance. Then in terms of monitoring our patients, we also monitor a response to see if they're doing fine. If they're doing fine, our patients, then that's treatment success. In terms of clinical, they feel much better, they've got more energy, they don't have any opportunistic infections. In terms of immunological, their CD4 count will go up. Then virological, their virus becomes undetectable. But at some point, we have our patients actually failing, failing treatment. And how do you realize, how do you pick or identify these patients who will be failing treatment? Then they will know someone was okay, but now they start developing new opportunistic infections. They are now sicker, someone is on treatment. Then their CD4 is no longer going up, it's no longer going up. Their viral load starts to increase. So if you see, patients, who are on treatment and they're experiencing some of those issues, what are the possible causes? So these are the possible causes, but the most commonest cause usually is people not taking their drug, which is poor drug adherence. Others, it might be due to issues with adequate drug dosages. Maybe long back, the drug potency might be a challenge, or they're getting drugs which have expired. Maybe there's poor drug absorption due to food, or there's drug interaction. They are taking, drugs, for other conditions, which might be affecting the levels of the drugs which they are taking. And one of the, the last three, they are very common in our population. The use of herbs, this is very, very common. I think you've heard the Tianche, forever living, whatever. Those things which are, those herbs which are sold within the supermarkets or within the streets, actually they are also responsible actually. So it's very common among our. Then unsafer sex, this is very, very common. Usually you tend to see this in most relationships. Maybe the woman is positive, the husband is not tested, or refusing to take medication, then leading to some of these challenges. So it really happens in most cases. If you see a woman married and they are not doing well, try to check if the husband is tested, if they are having safer sex, all those issues. So I think it's also a very common. Then this is very, very common with the gospel of prosperity, with all these famous prophets which we have within the country. Very, very common. And it's where you see people, they are pastor or whatever, they are spiritual father. They might, they claim that their HIV has been healed. So if you see someone, if within this program, if you see patients not doing well, before you really, it's wise actually to really assess some of these issues. Because if you assess some of these issues, if you correct most of these issues, then most patients actually, they can then, the viral load or the CD4 can start going up. So these days, the standard, so if a patient is failing treatment, in most cases they go into second line therapy. But before someone goes into second line therapy, we need to rule out the possible causes and those issues which I raised, to say it might be due to all those issues I mentioned. So usually before you switch someone to second line therapy, it is wiser to really first check for those things. As I mentioned, poor adherence is the commonest cause of treatment failure. So usually before we change patients on their treatment, it's nice to really look what are the possible things and which might be leading to them failing treatment. And then if you are sure they're actually failing treatment, we then switch them to second line. And the drug which you use for second line, they depend on the first line. But one of the key aspects now, in second line, we then give a protease inhibitor. These days, we don't give lopinivir, but we give atazanab, I think. So this is an outdated slide which needs to be. And in terms of monitoring our patients these days to see if they are failing treatment, we can monitor our patients either clinically, virologically, immunologically, but these days the standard way of monitoring our patients is through viral load monitoring. And this one is the algorithm or the recommended algorithm of how do we monitor our patients on this is the algorithm of monitoring our patients on treatment. So if someone starts treatment, we do them viral load after 6 months. So 1,000 is the cutoff, and if it's less than 1,000, it means they are fine. They continue on treatment. If it's more than 1,000, we then look for the possible causes, as I mentioned, and what might be really causing that, what might be causing what might be causing the virus to go up. And is it non-adherence or is it treatment failure? Usually, we do what we call enhanced adherence counseling sessions, and then we can repeat viral load after 3 months. If you repeat after 3 months, what happens? If it's less than 1,000, they may continue whatever they are getting. If it's more than 1,000, it means they are failing what? There's treatment failure. So remember, if someone undergoes enhanced adherence, you rule out all possible causes. They are taking their drugs earnestly during the 3 months, and the viral load is still going up. It means they've already developed resistance now. If you have resistance, it means the drugs won't work, and the viral load will never go down. So in that case, second line, you then switch them to second line regimens. So I think the schedule is just, first viral load after 6 months, then you go at 12 months, then yearly. So it's 6 months, 12 months, yearly. But if your viral load is less than 1,000 or more than 1,000, you then need to, to follow these steps which I've highlighted here. So this is what I was discussing prior. I was discussing most of the clinical management issues now. But now I will briefly discuss the programmatic aspects now in terms of how most HIV, in terms of how the HIV program is structured actually, within the ministry and within the most of the implementing partners. So I think we've heard of the HIV cascade of care. So the cascade of care, it just summarizes the processes or the steps which are involved in provision of HIV, services. But the first one, actually, we need to prevent new infections, and as the cornerstone. But in most cases, our efforts might not really, we still have a few who end up being HIV positive. Those who are HIV positive, we need to offer, we need to be able to pick those. We need to make sure we offer HIV testing services so that we can have a diagnosis of HIV. HIV, we can pick those who are positive. Those who are positive are supposed to enter into art care, and how in this process of entering into art care, that's the linkage to care. So they're supposed to be enrolled into care. Then before, we used to have another stage where we assess them for art eligibility. But these days, it's treat all, which means we enroll anyone into care, then we assess them clinically or psychologically. They're then following, and they're ready for art initiation. When they are on treatment now, our challenge will be then to make sure we retain them in care. And as we retain them in care, we need to make sure they are adhering to their treatments, and they are adhering to their treatments, and they are virally suppressed. So this cascade of care, I think if you check on your timetable, we have another topic where we'll be discussing current strategies towards meeting the 90-90 targets, which is from testing, from linkage, art initiation, viral load monitoring and retention. We'll then discuss what are some of the programmatic issues or strategies which are being implemented at each stage, and what are some of the programmatic strategies which are being implemented to try to prevent new infections, in terms of HIV testing, in terms of enrollment into care and linkage, in terms of art initiation, in terms of adherence, retention, and viral load monitoring. So we'll try and get people from within the AIDS and TB unit to give us talks on those various elements in terms of HIV diagnosis, enrollment, art initiation, adherence, and viral suppression. So these would be like separate lectures where we then discuss the concept, actually, some of the things which are important and key for you to understand. I think for today, let me end here. Then we can continue next week.